So, good evening, everyone. I am Dr. V. Mohan. Let me take this opportunity to welcome you all. We have not had a press conference for a very long time, but this is a very important development which we are going to present to you today. As you all know, diabetes is a disease or a disorder which, if not controlled, can lead to all kinds of complications affecting the eye, the kidney, the heart, the feet, the nerves, and all other organs. In fact, they say from the head to the foot, it can involve all the organs, including the head and the foot. So that's how widespread diabetes effects of diabetes can be. Some years ago, through long-term follow-up studies, we showed that there is an ABC mantra. And this ABC mantra, there is also a D. So the A stands for A1C, HbA1c. B stands for blood pressure. C stands for cholesterol, particularly the bad cholesterol or the LDL cholesterol. And D stands for discipline, which includes diet, not smoking, doing physical activity, and so on. So we really do not know in a large country like India, what is the status of diabetes control? Till recently, we didn't have much data. Now we have some data from one or two cities. From Chennai, we have been having some data. From Delhi, through our collaborator of Nikhil Tandon, we have been getting some data and we published that. But on a national level, in all the states of India, urban, rural, what is the status of diabetes control? How many people have got their diabetes under control is something which is very urgently needed. And as you know, health is a state subject, and therefore for every state, it is needed. And that's exactly what the ICMR India Diabetes Study or INDIAB Study has done. We're very happy to report that just last night or early morning today, a very big paper was published in Lancet Diabetes Endocrinology, describing the status of diabetes control in the whole country. And to present this, we have in front of you Dr. Anjana, who is the first author of this paper. In fact, she and her team from the Madras Diabetes Research Foundation have been looking at the whole study. Actually, it's taken us 10 years to complete the whole country because every nook and corner, every state of the country has been covered. So now Dr. Anjana will make a presentation just describing the highlights of this study. And then thereafter, if there are any questions from the floor, we would be happy to answer. So over to you, Dr. Anjana.
Thank you very much. And good evening and welcome to this evening's press conference. My name is Dr. Anjana and I'm the Managing Director at Dr. Mohan's Diabetes Specialty Center. The purpose of this press conference is to let you know about a publication that has just come out today in the Lancet Diabetes Endocrine. So the question we are asking today is achievement of treatment goals in diabetes. In those who have diabetes, you have certain treatment goals. Are we doing enough? That's the question we are asking. So for this, as Dr. Mohan explained some time ago, we have data from the ICMR INDIAB Study, which stands for India Diabetes Study. Now, what is this study? It is a national survey of every single state in the country, state by state by state. We have studied and looked at diabetes, hypertension, cholesterol, etc. in the whole of the country. It's funded by the Indian Council of Medical Research and Department of Health Research, Ministry of Health and Family Welfare, Government of India. We have studied all the 27 states, the 2 union territories of Chandigarh and Puducherry, and the National Capital Territory of Delhi. In each of these states, there is a PI who is either a leading diabetologist, he's the principal investigator, or the head of the community medicine or DHR or government there. And like that, every single state has now been completed. Today in the study, we have more than 1 lakh individuals enrolled in the study, making it one of the largest studies ever done. So this is how it was done. It has been done in phases depending on how the funding was released by the government. And this is how it is. This is the overall prevalence of diabetes in the country. And this is across this presentation, you will see that blue represents men, pink represents women. So overall, you will see among men and women, 10% and 9% across the country, urban, rural, everything. But that is not the story for today. The story for today is, among those who have diabetes, are we taking care of A, B, C? A stands for A1C or sugar glycemic control. B stands for blood pressure and C stands for cholesterol. And we are looking at the ABC level. How have we defined this? A1C less than 7%, blood pressure less than 140/90, and a cholesterol, LDL, which is the bad cholesterol, less than 100 milligram per deciliter. So these are the definitions used in the study. So how did we do? Out of 120,000, 1,20,000 people approached, we had those with self-reported diabetes. We had to leave out all the people who were newly diagnosed for obvious reasons. And we have about 6,000 people, 5, 7, 8, 9 in the study. So let's look at glycemic control or A1C. Now, here you have the men and women showed, and we have 3 columns here. The good, which is what we define as less than 7. Fair is 7 to 9. And more than 9 is poor control. So you can see about a third of individuals, 35% among males and 36% among females, have good control of their A1C. So this is what it should be for protection of all the organs. Only 30% have good control. The rest are out of control. Urban, rural, 34.8 urban, 37.5 rural. So again, color coded, red is urban, green is rural throughout the presentation. So you can see again in urban, rural, only 37% have good control. So the rest of all the people with diabetes do not have control of their glucose. Now, what about region-wise? Again, this color coding will be the similar one, but the north region includes the states Chandigarh, Delhi, Haryana, Himachal Pradesh, Punjab and Rajasthan. South will be Andhra Pradesh, the undivided Telangana and AP. Karnataka, Kerala, Puducherry and Tamil Nadu. East, Bihar, Jharkhand, Odisha, West Bengal. West is Goa, Gujarat and Maharashtra. Central, Chhattisgarh, Madhya Pradesh, Uttar Pradesh, Uttaranchal, and Northeast are all of the northeastern states. So that is the division you will see here. So in case you're worrying where your state comes in, this is the reference. So again, this is people who have A1C less than 7, good control across the country or in the 30s. Slightly better in the northeast, okay, a little bit in the west, but 30s. Overall, across the country, 1/3 of the population only have good control. Now, let's talk about self-monitoring of blood glucose. What is this? This is the glucometer test that you do at home, that you can do at any time. So this is called self-monitoring, when the patient can monitor. So all those with diabetes, it is recommended that they monitor regularly. How many people are monitoring? Among those with diabetes, only 17.5% do this testing at all. I'm not saying daily, weekly, monthly, at all. Do you do testing? Yes, no, you have only 17. On those on insulin, patients taking insulin every day, do such people test? Only 36% men, 37% women. Overall, hardly 37%. Even those who take insulin. So very poor level of self-monitoring in the population. Similarly, if you do this urban, rural also, not much change. Urban area, little better than rural area. That's all. But overall, people are not monitoring regularly. Let's move on to blood pressure. We finished about the sugar control. Now let's move on to blood pressure. Again, male, female, overall, what is the blood pressure control? It's better than sugar. That much is certain. But even then, not great. Overall, about 49%. And men and women equal. Control of blood pressure. Urban, rural, again, about 50%. So 1 in 2 people have good control of their BP, whereas it was much poorer for sugar. Again, region-wise, you look at it, the numbers are about the same. About 48 to 50%, half of the people who have high blood pressure have their blood pressure under good control across the country. Little bit here and there, it goes up and down, but overall it's about the same. Okay. Cholesterol. Again, you'll see male, female overall here. How many people have a total cholesterol less than 200, triglyceride less than 150, and this is the actual C. LDL cholesterol less than 100. If you look at LDL, overall it's 40%. It's slightly better for total cholesterol and triglycerides. So of the three parameters, cholesterol is best control, then blood pressure, then only blood glucose. Blood glucose seems to be the worst of the three. So this is how it is among men and women, little ups and downs here. Women don't do so well in terms of cholesterol compared to the men. But if you saw for sugar and you saw for BP, they were equal. Here, the lipid control is slightly less than women. Urban, rural, again, little ups and downs, but about the same, about 40% overall with LDL cholesterol in a good control range. Across the country, are the numbers different? No, little bit better in the Northeast. The Northeastern states are doing a little bit better compared to the rest, you can see, but otherwise it's overall about the same. Now we come to medications. The first question that we ask, is your sugar under control? Why are you taking medicines? Are you not taking medicines? So that question comes out next. Let's move on to medications. Now these are medicines for diabetes control. These are tablets, oral hypoglycemic agents. This is insulin and total. So the first bar is total on any glucose lowering agent, tablet and insulin. So you can see for those, whether you're a man, woman, urban, rural resident, you had the actual reporting of taking medicines was high. 88% of people said, yes, I'm taking medicines. Insulin, about 10 to 11% across men, women, urban, rural, etc. Insulin, whereas a good number of people reported taking their medication for diabetes. What about blood pressure? Again, here, the actual number of people reporting was about 30% with self-reported diabetes on blood pressure medication, and slightly better in women compared to the rest. What about lipid medication? Poorest. Given here, only 15%. Now remember, these are people with diabetes, whether they are on lipid lowering or blood pressure medication. So you'll see it's about 15-16%. Now, we finished about level of control. We finished about medication use. Now, what about healthcare seeking? Where are people going to get their diabetes treated? Is it private healthcare? Is it government healthcare? Urban area, 68% private, 32% government. Rural, again, you have a lot of people on private here. Males, private, again, you have 62% overall and 38% taking government care for treatment of their diabetes. Now we move on to the health habits or the various lifestyle measures. The first thing is about the various, so I have here smoking, alcohol, fruit and vegetable, there are two. Now the WHO says that in order to be healthy, you need 5 servings of fruits and vegetables per day. But in India, because that consumption is so low, nobody meets that recommendation. We have our own recommendation, which we look at 3 servings. So that's what at least some numbers you'll get in that. If you take 5 and all, it's in single digit, the numbers. And then you look at physical activity. So now let's look at it. This is across men and women. Smoking is at about 18% in men. Women, it's very low. 20% alcohol use. Fruit and vegetable, let's look at the 3 serving. It's about 19-20%, less in women compared to men. Physical activity, again, about 25% more in men compared to women. Now this here is a heat map. You're not supposed to look at the individual numbers. You're supposed to look at the colors. If you can just put off these lights, that'll come out well. Now, what does it mean? On the y-axis here, in alphabetical order, you have all the states in alphabetical order given here. Then you have all of the different parameters. So you have ABC targets given here, A1C, cholesterol, etc. And you have health habits given here. Now, if you are in the good range, then it's colored green. If you are in the fair, it's colored orange. And if it's poor, it's in red. So what it tells you, one shot across India, HbA1c is in orange. That's glycemic control. Whereas blood pressure, there's lots of greens here and there. Total cholesterol, we're doing better. HDL is in orange and green. Okay, so this is good cholesterol in our population, well known, very low in our population. Triglyceride is almost everywhere in red, mostly orange. Smoking, alcohol, greens, oranges, they're here. Fruit and vegetable, mostly orange. Physical activity, mostly red. It's no surprise. Okay, how many of you walk every day? You're all in the red. Okay. Now, finally, we looked at what are the factors that are influencing glycemic control. So they're separate for each of these various parameters. Okay, this is the logistic regression. And finally, for combined A plus B plus C, what are the factors? Being a man is positive in achieving control. More men achieve than women. Similarly, rural areas, it was better than urban areas. Higher education, higher control. Shorter duration of diabetes, better ABC control. So these are the 4 factors that finally came out as significant. So I'll conclude by saying that 1/3 of individuals with diabetes have good control of their A1C or sugar values. Half have good control of BP, and about 40% have good LDL cholesterol control. Or the proportion of individuals attaining A plus B plus C is only 7.7, and that is very, very horrible. Single digit number for all 3 controls. No significant difference much between urban and rural, and there is a lot of difference between regions, especially in the Northeast. Now, majority of individuals relied on private health care. Less than a fifth did any self-monitoring of their glucose levels. 20% only consumed fruit and vegetable, that too only 3 servings, not the recommendation, and 25% did physical activity. So what are the factors that were good predictors of good control? Higher education, male sex, rural residence, and shorter duration of diabetes. Thus, by and large, the story is that we have a long way to go. In this country, we have more and more explosion of diabetes happening. It is vital that we make these people understand that getting good control of their sugar levels, blood pressure, and cholesterol levels will lead to a long and healthy life with diabetes. Thank you.
Thank you, Dr. Anjana. So if there are any questions from the floor, we'll be happy to answer. Dr. Anjana can also answer. If I am required to answer, I'm also here. I can see that some people have also joined online through Zoom.
If those on Zoom have a question, please raise a digital hand. And here, of course, anyone can raise a hand. Any questions you would like to ask?
Ramya, yes, Ramya, go ahead. Ramya's digitally from the Hindu.
Yeah. Hi, Doctor. Hi, Dr. Anju. How are you? It's good that we have this data finally, but I just have an initial question about you mentioned about the shorter duration of diabetes. What are the ranges that we basically looked at? What are the ranges that we have looked at in terms of duration of diabetes in patients?
Do you want me to answer that, or are
you go ahead? You go ahead.
So we have durations that are of different ranges, Ramya. So we have less than 5 years, then we have 5 to 10 years, and then more than 10 years. So the risk is for more than 10 years. And as you get lesser and lesser from that 10-year mark, it gets better and better. So for 5 years,
perhaps we can explain it this way, Ramya. First, when people are diagnosed, they are perhaps a little bit more worried about their diabetes. And as time goes on, as in any chronic disease, asthma, rheumatoid arthritis, diabetes, anything, they tend to kind of neglect after some time and give up. Some of them get depressed. Some of them just don't care anymore. I can't do this anymore. So that's one thing. Second is that it gets more and more difficult to control with duration, because what happens, your beta cell function is going down. So when you're diagnosed, you'll have some beta cell function. So with one metformin or something, you'll be diagnosed. As you go on, a second drug, third drug, and all will be needed. And unless you're going regularly for follow-up, they will not intensify their treatment. Clinical inertia will set in, and the control will get worse. So the danger, and that's the time when the complications also will set in. So I think those with longer duration need to go back more often to the doctor to screen for complications. And I think that's one of the things which came out.
So you would say go back to the doctor every 3 months?
So I think Anjana published a paper on this about 5 or 6 years ago, or maybe a little longer, where we looked at, because we keep saying come back 3 to 4 times a year. but there are costs involved, whether it is government or private. Even if the government, they have to travel, go there and so on. So we did a study where we looked at those who came regularly for follow-up, at least 3 times a year, compared to those who came 1 time a year or less than a year. Within 9-year period of follow-up, what we found was that those who come regularly for follow-up, they had a 50%, at the beginning, it's a very large series, about 2,000 patients. This is in the clinic whom we followed up. And what we found was at the beginning, nobody had any complications. We ruled out all those who already had complications. And then over a 10-year period, when we followed them up, we found that those who simply came for the follow-up, they had a 50% lower risk of both eye disease as well as kidney disease, which is very, very significant. And if you calculate how much more for those 2 extra visits that they spend, it's nothing. Because for a review visit, you really need a HbA1c and a blood sugar and a consultation or something. You're really not going to spend a lot of money on that. But when they don't come, the A1c keeps on rising. So suppose it's at 7, only 30% have achieved 7. But let's say they've reached 7, then they won't come. Now I'm under control, I don't have to go. It'll become 8, they won't come back. It'll become 9, they won't come back. Then when it reaches 10 or 11, they become sick. They develop urinary infection or something, they become weak, then they come running. They've lost all that time, that much time, the beta cell function is going down, complications are the seeds for complication are being sown. So that is a golden period. And this study points out very clearly, because earlier they'd say it's all clinic-based data, city-based data. Now it is telling us a whole country's data. And both in urban as well as in rural India, even things like physical activity, the things which people should be doing, are taken only very simple things: sugar, blood pressure, cholesterol. You're not taken many complicated things. And using generic tablets, you can get all these under control. And in spite of that, it's not happening. So it's a wake-up call. And even during COVID, you know that it's people who did not have the sugar under control who had all the risk. So suppose, heaven forbid, like COVID or COVID again, 4th wave or something else happen, it's these people who are going to be hit very badly. Agree, Anju?
Yeah. Thank you, Dr.
Go on, Ramya. Go on.
I don't want to hog this, but one more question. I'm intrigued. So you said initially there were 4,000 samples from each state, but only 1,200 urban and 2,800 rural. Was this sort of a deliberate choice to pick more rural patients, or was it just?
So how it works, Ramya, is that we have to base this based on the population distribution. So we have picked, if you take a state, we have to pick based on geography, so across. We have to base on population size, population distribution, and socioeconomic status. So we have to check all of these things. So we use the census data, which is the base data for all the sampling. And based on that, using the NFHS3 base, we have built all these parameters, which I just told you, population size. So India's distribution of population, urban and rural, falls in a similar manner. We have also sampled.
It's about 65, 35, something like that. So in that same population.
So it respects the basic distribution of population.
Correct. If you actually lay this on a census population, age-wise, male, female, it will lie exactly on
top of it, because we use the same distribution. So.
Thank you.
Anybody else from the audience?
Suvi, can you hear me?
Go ahead. Who's this?
So I am Suvi from Money Control.
Go ahead.
I wanted to understand, I saw the presentation and I wanted to understand the findings of the study. How do you think, what policy implications it may have on a larger scale, as you know, the burden of non-communicable disease in India rises, and there is a lot of emphasis nationally on going ahead about these programs.
Policy implications, Anju. Go ahead.
So, sorry, I wasn't able to understand.
So the question was, in the light of the study, what are the policy implications since we are finding such poor control? What will be the policy implication? What would we tell the government if they ask us, okay, what do you want us to do after the study? What will you tell them?
So that is a very, very important question. I think something that all the press should ask. What is it that the government should do? The need of the hour is education. The need of the hour is screening. The need of the hour is availability, accessibility of medicines. The need of the hour is being able to regularly monitor these patients to see that they actually achieve this control. People think, Dr. Mohan made a very, very important point when he said, people get their A1C under 7 once, and then they think, oh, it's under control. But it won't stay under control forever unless you take that effort. And I think that is what needs to come as a policy implication. What should the government do? The government should encourage physical activity starting from schools. The government should encourage healthy eating, make available fruit and vegetable cheap so people can buy and eat. The government should educate that someone with diabetes has to visit a doctor every 3 months, maximum within 6 months. They have to see a doctor twice a year. You have to do the sugar test. You have to check your blood pressure, check your cholesterol. It's important. Keep it under control. Educate about the numbers. Make people aware. Self-monitoring. Okay, you see the doctor once in 3 months, once in 6 months. But what's happening every day? You have to be able to monitor and check. The self-monitoring so poor. If you are able to check and monitor, you can control it. Very, very small, simple things can be taken up by the government and done to make large effects in a population at large.
So there are 2 questions from Shushmita, and so I'll answer what's come in the question box. So I'll answer that. So Shushmita, the first one was, how has the pandemic influenced the study? Now, this study took about 10 to 11 years to do, because it had every nook and corner, including the Northeast, every state, and only the islands and Jammu and Kashmir are left, which is now going to start in the next phase of INDIAB. Otherwise, all the 30 states are over. So a lot of this was done before the pandemic actually kicked in. And so it did not actually affect our study to a large extent. Of course, there were a few months when it was at its peak, when we had to stop all work, but then we quickly picked it up again. The states where it was not, the pandemic was not very active and so on. And so to answer your question, it did not impact the study in a way that, we had to give up the study or get a lower response rate. We had to answer your question about the quality. This study is one of the most quality conscious studies. So we had teams from ICMR making field visits, expert teams, to every state in the country where it was studied. And they spent a day or two going through the records, going through the blood samples, how they're collected, going and asking the individuals how they were taught about the sample being taken. It's a pakka study, and that's why it's getting published in journals like Lancet. And so the quality the measures which are built in, you can write books on it. In fact, we have SOPs written, and this study can be a model for many other studies, because as you know, sampling a country or like India with so many states, so many languages, so many cultural differences is a nightmare. But we somehow managed to do it. To answer your question, how the newly diagnosed cases were managed, again, from the beginning, ICMR made it a mandate that every new case, every new patient who was diagnosed with diabetes, now remember, this is a screening test. And so the test may show that somebody has diabetes. That's not a diagnostic test. It's a screening test. So what we did was, each and every person who was diagnosed was taken to the nearby doctor, very often to the government places, where at least an initial treatment was started. They were also asked to, same thing for blood pressure also. So if they had very high cholesterol or blood pressure or sugar, we ensured that there was a continuity of care. Number 2, a health card was given to them. And all this is, of course, done free of cost as far as the participant is concerned. And so that is given to them. Number 3, we gave tips to them. So what diet to take, what exercise to do, a health card. And at the back of the health card, all these tips were given. Even if they had pre-diabetes, how to prevent diabetes was given to them. All this was given to them. On top of all that, every sector that we surveyed, whether it's a district or the whole state or whatever, to the district medical officer in that region, we said, this is a study conducted by Government of India, ICMR, and these are the new cases which we have picked up with diabetes in this area, and please follow up these people. So that was also done. Normally in an epidemiological study, they just screen and then they leave it. and therefore there are ethical concerns. Because of that, the government was insistent, and the ICMR is insistent, that this should be a model study. So every single person, we went back and did that. In fact, in the next phase of INDIAB, now that 10 years are over, Tamil Nadu and Chandigarh and the Maharashtra and Jharkhand, where we started first in the phase 1. So those have now completed 10 years. We're going back to those states where it's over and trying to pick up those people who already had diabetes there and seeing what happened to them and follow them up and look at, whether some of them unfortunately might have died. So we are trying to look at all that. So it's much more than just a diabetes study. We have extensive data coming out shortly on diet, on physical activity in different parts of the country. This is just the quality thing, but there is much more data which is going to come out. This is like a treasure house of information. The fact that it's taken 10 years, it's been well worthwhile. And that's why INDIAB is so highly rated. Any questions from there?
He's asking whether the report has been submitted to the central government and all. So the paper has just come out today, sir. And yes, ICMR does have a mandate for us to make reports. Not only should it be available, it should be publicly available to researchers, government organizations, states. So each of the state data has been sent to individual state. Tamil Nadu state was submitted.
There is a PI for each state, you can tell them. So in each state, there is a principal investigator from that state, usually from a medical college or from the government. So that person takes a responsibility. In many of the states, they then hold dissemination workshops to disseminate this data. And even the prevalence of diabetes itself, when we earlier had the data at ICMR itself, we have had dissemination workshop where the DG ICMR, Ministry of Health and others are invited, WHO and all the health secretaries and others were all invited, and they were all given copies of the report. So we give it back to the respective governments so that they can decide what to do for the particular state, because health is a state subject.
And in Tamil Nadu, it was handed over to the health secretary.
Health secretary. We ourselves went and handed it over. Ramya, you had another question? Oh.
Sorry, there's someone asking a question here. 1 minute. Yeah, just use the mic so they can also hear.
You said the government should take the initiative.
Yes.
Telling the people.
Yes.
Do you have any tie-up with the government? Private hospital having tie-up with the government?
We don't have at the current time. Our collaboration is funded to do the study. That's all. We don't have any other collaboration with the government to do a public-private partnership. But the government should take such initiatives because, as you saw, there's so much of private healthcare. So there should be dissemination strategies where government takes small messages, walk 10,000 steps, eat fruit. They used to have that anda thing. Healthy, like that, government can take each of the things and
they are already taken actually. But
okay. No, but see, the government initiatives are very, very narrow. For example, you take Chennai City. Chennai City has some good initiatives in terms of, let's say, physical activity. They do have, this road blocking for traffic so that pedestrians can walk, more people can walk, etc. But when you take India as a whole, it is very lost. And only very certain states, their infrastructure and government health and their ability to disseminate is coming out itself. You can take 3 or 4 only in the whole country. The rest of it is completely lost. So
I saw another report in some of the newspaper. There's age group also does make a difference. Age group, yeah. Up to 20 years, they have more control over diabetes.
Actually, it's the other way around. It's the other way around. So for diabetes, it is one way, and it also for BP, it's another way. So let me explain this to you. For diabetes, if someone gets diabetes when they're 20 years old, okay, the reason they're getting that diabetes is most probably either because they're overweight, but mostly because they have some defect, pancreatic defect. Okay, so this leads to a very severe form of diabetes. So usually these people have difficulty in control, number one. Number two, young people are either working, going to college, have jobs, have stressful lifestyles. So the ability to do that exercise, keep the diet, take the medicine, go see the doctor is much less compared to a retired person. Okay, so 65 plus, they have more time, they're retired, they are more, have more energy, go see the doctor, do things in a more, this thing way. So that way for glycemic control, the age is opposite. Younger the age, worse is the control. But for blood pressure, it's the opposite. That age is a naturally factor that increases your blood pressure. So as you age, higher your blood pressure. So for different things, it's different.
Couple of things to the gentleman who asked. We do work with the government, may not be in a private partnership, a public partnership kind of thing, but in all their committees where they are tackling non-communicable diseases and where diabetes inputs are needed, they often consult us. And so I sit in both central government and committees, as well as in the state government, Tamil Nadu government also, where they call us and they ask us for opinion. For example, when COVID came, how should diabetic patients be managed? I was part of that committee along with the government doctors. So we work very closely with the government and all this. And in all our rural work, for example, where we have adopted more than 40 villages, the health secretary and the government of Tamil Nadu has allowed us to work in those villages to help the villagers to keep their sugar under control. So we do work quite a lot with things. The last point about the young age, why these people have more, why they get it at young age, apart from the obesity, which Dr. Anjana mentioned, genetics is usually stronger. Because if you don't have a family history of diabetes, father or mother, you tend to get it when you're 40, 50, 60 years old. But if you have strong family history, father and mother are diabetic, then the gene becomes very strong. Then you get it at a young age, and then it becomes very difficult to control because you have a very strong gene effect, plus you have obesity. And that's why it's very difficult. Ramya had one more question. She had raised her hand. Ramya?
Yeah, hi, Doctor. So I'm just wondering, I'm trying to understand whether the results that you've seen are irrespective of the quality of care in hospitals, because as you very well know, there is a range of medical care that is available in India. But in places where, you might expect a sort of a lowering of quality of healthcare, probably in the Northeast, we see rather good results, good control. Is this, basically, are you trying to say that control of diabetes depends, or even non-communicable diseases, metabolic diseases, depends largely on the individual, the patient, with the health services systems to support his recovery, etc.?
I think it's both, Ramya, because the individual also has to take care. But then if there is no healthcare facility available, if they go to a state where in our state it's different, Kerala is different, Goa is different, Sikkim is different. There are a few states which are, very different. But there are others where the primary health center metformin is not available, even if they go. Insulin is not available in many places. So that also influences the poor people. They have to go and get the free medicines only. In some of them, there's no doctor available there. So that also makes a difference. Northeast, there are other factors also. So for example, hilly areas, if you go to many of the Northeast, their house itself will be in 2-3 levels. They'll be walking up, down, bringing water. That you don't get in the plains and you don't get it in many other states. So that will influence your control. It will influence, you're getting a physical activity, your steps, your burning calories, all that will come. In some of the rural areas, they don't have much to eat. So they can't eat much. They can't eat junk food and so on. That's why you'll find the rural people probably doing even better than the urban places in some places. So I think it's a multiple factors, but the individual also really counts. And going for a checkup, I think, is very important. So this going for a checkup at least 3 times a year and getting a HbA1c done and your blood pressure checked, and at least once a year a cholesterol being checked, and encouraging people to do self-monitoring of glucose more with the glucometer at least once a week or twice a week or something. Even that they're not doing. They have a glucometer, but they don't use it at all. They think it's not important. I'm feeling fine, so why I should do that? Laissez-faire attitude is not good, because diabetes is a silent killer. While it is damaging all your systems, it's not going to give you any warning. Till suddenly your eye starts, your vision goes down, it's bleeding there, or you go and you find your creatinine gone up. Then you've lost the race already, because kidney is already gone. And it doesn't tell you before it's going. It's not going to produce all the symptoms until you're in last stage of kidney failure. And so much can be done before to prevent all that. On one side, we are showing people living up to 100 years of age and not doing well and not doing badly at all. And there are others who suffer in their prime of their youth. So both are happening. So I think these are very simple diseases to treat. It's not like cancer or something. To diagnose itself, you need MRIs and biopsies and all. Here, just glucometer and simple things you can diagnose. And generic medicines are quite cheap. So keeping it under control, it's a movement which has to occur all over the country. That is what this whole thing is about.
So Ramya, I think I would like to say that the study results reflect the quality of care in various places.
Yeah, so it's definitely not the same in different places here. But surprisingly, see, even in a place like Kerala, if you see, you would expect it with 100% literacy and all, they'll have fantastic control. 80% will have HbA1c under control. It's the same in Kerala. Nothing much happened there, So that shows that the individual also, the care is provided. In Kerala, you can't say nothing is available. Everything is available there. Tamil Nadu also at large extent. But if you see overall, the differences are not huge. It's not that one state is so good and the others are so bad. Roughly all are in the same boat with minor differences here and there.
Thank you, Doctor.
Thank you. Are we done? Any other questions? So if there are no further questions, I would like to thank you all for coming, and please enjoy your hospitality. Please have a cup of tea or whatever is offered. Unfortunately, I'm at Puttaparthi. I've come here for some functions and meetings, so I could not join face to face, but great pleasure to meet all of you, and I hope to have more interactions with you. So I'll take leave now. Thank you.
Thank you. Thank you for coming.